So I'm just going to give you a little bit of information about a project that we've worked on. Complete different end of the scale from what Sunky Moon just talked about. Very focused on solving problems for a bunch of clinicians that we've met in Europe. So I've called it from patient assessment to the European Registry. Really what happened here is this came from the European Registry back towards clinical assessment. About Open App, I'm Mel McIntyre, I'm Managing Director of Open App. We're a software development and support company, I suppose, primarily. We deliver solutions in open source. Whether we call them open source solutions or not is probably always debatable. We do provide the code for everything that we develop, but we don't necessarily develop community around our applications. Maybe someday we will. We are developing or are delivering a cloud-based clinical assessment platform, which is growing from the Cystic Fibrosis project that I'm going to talk about. We are also at the conference here, teamed with DSS from Florida. I suppose we're looking at bringing Vista to the UK. We have been working in Ireland for a couple of years, demonstrating Vista in Ireland. Cystic Fibrosis Patient Registry, what are they doing there? Collecting information, surveying, trying to improve the situation of cystic fibrosis patients around Europe. They've been running, I would imagine they've been running for about 10 years. So as a clinical registry, they're one of the older, more mature registries, even though it's not a very widespread disease. In Ireland it's about 1,000 patients. UK, we got the UK registry data recently, about 10,000 patients. It's the biggest single registry in the world. I think the US is about 8,000 patients. Not so big. So we got Germany, France. We have 22 countries on board, which means our software will be used probably about 220 hospitals around Europe, which is it's a pretty good deployment, and it's developing a pretty good software delivery model for us. The goals for the software, because a couple of challenges that they put in front of us. I mean, obviously a registry is a database, forms is a database, no big deal. But the problem is getting countries to engage, whether it's to agree on common data models, you know, the Germans, the French, the Brits, the Irish, the Slovenians, whatever across that, whether it's that they don't have resources and financial. So it to accommodate different country situations. UK, Germany have their own system. Denmark, Ireland, France want to use our system, want to use new software. Want to accommodate countries with very strict data protection. I would say data protection interpretation, because that's probably, especially around the patient identification, where they want to have their own instance of the software running in their country. Allowing countries and centres to extend the core data model. And this is a big deal because it takes technical teams years to agree on the core data model. So then one country wants to collect some other data outside of that for some clinical trials or for some other reason. They can't extend the model, so they wanted us to give them something that would let them do that. So we put a tool in there where they can extend, at a national level we can extend the data model, and at a centre level we can render the data model in different ways. So we can render it differently for paediatric hospital than an adult hospital maybe. So we start to soften these technical wars between people, recognising the different things that people need to do. And no barriers to participation, so because we develop an open source, we don't have license barriers. That's a big help. So we want to roll a registry out in Romania, we don't have to start talking about who's going to pay for it. We give them user ID, a password, set up an instance, and then they obviously have to go and do the work of engaging. But there isn't software barriers, license barriers, that type of stuff in the way. The other thing we want to try and do is make it easy for doctors to participate, because it's doctors or their nurses sitting with them that do the data collection. So part of our problem with registries is we have a tendency to collect data but not give anything back. So we built the system in such a way that the doctor gets everything back relative to the patient or relative to a centre or a bunch of centres, whatever way they're working, as they enter data. So that is kind of our incentive for doctors to engage with the registry. And what that means is we're going to extend that doctor-patient encounter or assessment, we'll start to extend that so that it becomes much more of a health record, electronic health record, for the specific CF purpose. We had some goals ourselves. Open App, we're trying to build a more generic platform from a software perspective. So we've taken this same platform and we're deploying it as a national joint registry in Ireland for hip and elbow and knee implants and that type of stuff. Because through this platform then we can engage the patient to do patient-recorded outcomes, pre-op proms, post-op proms, post-op complications, transfer patients across hospitals or share patients across hospitals. So they're not kind of rocket science issues, they're subtle, soft issues, but they're the issues that people are having to deal with. So we built a more generic platform to do that. We're integrating with PAS systems, with lab systems, in surgery we're integrating with the surgery system. And we're doing some work on trying to underpin it with clinical data models and with clinical terms and terminologies. So we're looking very hard at open air as an underpinning, but we haven't implemented that in CF as yet. The different countries we're dealing with, we've got countries that are using our instance of the European system. So they've got an Austria folder, if you like, or instance, Bulgaria and Greece. We've got other guys who use their own systems like the UK and Germany. And then we've got in Ireland and possibly in Holland, I'm not quite sure, they're going to implement an instance of our software locally in their own place. The kind of data we're dealing with the patient identification data, and I've identified it separately because obviously this is one of the huge kind of conundrums that we have to deal with registries. When a doctor deals with a patient, they want to know the name, face, they want to know they're dealing with the right patient. When they transfer data out, they want to make sure they don't transfer any information out. So to have a centralized system that can do both is obviously a challenge for us. So we got the patient identification. So we separated that from the demographics, and then we start to step into the encounter of the patient with the provider. We have what is generically in software is called ETL, extract, transform, load, where we extract the patient-doctor encounter data and create an annual summary, and that's what becomes a record then for a registry. And that's a pretty standard process. Typically gets done on paper with medically trained people wading through charts, trying to pull out the most relevant entry for that year. So we've generated a process. It fits as ETL in the software world, very specific to these people. With the CF people, then they have statisticians who validate the data, validate all the values, for this age of a person, that this is a possible value, that type of stuff. So we built in tools for the statisticians to feed back to the centre, and it appears in the forms if they think that there is anomalies. Like we had 176 centimetre heights, people said were invalid, and other people said well, they're the values. So we built in tools that we can feed back the errors, we can override the feedback. The soft type of things that let us apply the rules, but not let the rules block us from going forward. And we have the registry itself then, and the tools around that going the wrong way. And that's kind of the way we deploy it. We have a European instance, we have a failover instance and all that type of stuff. But we got a bunch of countries with their own folder. They use a summarizing process. They pass it through the statistician into the registry. We've got the UK, Germany, France, a bunch of other countries who prepare their data somewhere else, bring it into the system. And then we have an instance of it running in Ireland and potentially running in Holland, where we're doing it locally. And the reason we're using Ireland is we're actually going to take the encounter, patient encounter, and we're going to start to extend that into being more of a health record with a very strong cystic fibrosis emphasis. The data protection issue around patient identification, obviously it's only available in the centre. The name and patient identifying information, and only de-identified data is passed out of the centre to the country or to Europe. And we've got a map that looks something like that of how we transfer the information up along the chain. And we've implemented some hashing stuff here so that we can identify at the country level if there are potential duplicates coming into the system. And what we're doing there is we hash first name, last name, date of birth, gender. We hash them all separately. So we do kind of a probabilistic matching. So that if, somebody may misspell one but not misspell the other, again, from experience of doing these things, you try to soften rather than expect everybody to spell the name the right way. So we've got some technology built in there to do that. We built two pieces of technology. One was a web service that sits in the hospital where they manage the labels file, so that the name to ID matching, only available in the hospital, completely under their control, not under ours. When they configure a center, they configure a web address so that they can get access to the labels file and see the names. We've done a different approach to that then as well, because some hospitals just won't be able to do that kind of setup. So we've done a different approach where we store encrypted data in our system, but the encryption key is held by the hospital. And that will be more likely to be used. The first option is the one that the zealots like, security zealots, but the pragmatists will end up using the second one, or they won't be able to participate. We built in some technology then to allow countries to extend the data collected. So this is, because these became big issues. European Registry lost the UK, they lost Ireland, they lost a whole bunch of countries because they couldn't extend the data set. So we've got a core data set now that we've agreed at European level, and then we built in tools so that at a country level we can extend the data model, like something like hair colour or eye colour, these types of things that people may want to collect. And then at a centre level we can lay out their form and decide, so we can lay out a paediatric form different to an adult form, maybe hide some fields in a paediatric hospital, hide some other ones. So people are doing a clinical trial, 3 or 4 hospitals may show some new fields. The other hospitals don't even have to deal with it. So we built that in at a forms level. And again, that's kind of getting us over a lot of the political issues of how you get these systems deployed. And we built some technology, and that's kind of what it looks like. And over here, whether a value is required, and what the maximum and minimum validation numbers and all that type of stuff. That could be done in the hospital. We don't really expect that people will do it, but the tool is there to be available in this sort of open approach. We also then built in the ability, we built the core system. We originally built on Indivo, which is a project out of Harvard and the Boston Children's Hospital, which is a patient-controlled health record. But we ended up having to break so much of the rules because we didn't really want patient control. But we moved away from the Indivo technology, but we brought a lot of the document control thinking into our own design. But what that allows us to do then is it allows us to share. So we've got, because you've got kind of people go to their local hospital for care, but they go to the specialist hospital maybe once a year. So we allow the local hospital to share the record out with the specialist hospital. We also allow transfer of the record. So if somebody transfers from pediatric to adult services, is a pretty standard one, so they can transfer the record. Again, it's another subtlety along with a few of the other ones that we've been doing, very specific to their problems, and that's very specific to their problems, but driven by their doctors saying these are the things that stop us using the system today. I got a lot of stuff in here on data quality because we've got like 3 different levels of data quality. I'm not going to take you through them on the second day of the conference. But just really to say that there's error reporting mechanisms built into the system. A lot of the systems that we built, I was actually director of quality with a large American corporation for quite a few years. And one of the aspects of the quality philosophy that we tend to implement was that the people who need data most are the people who do a job. So if somebody's collecting data, they're the people that need to know first that the data is out of range, that there's a problem with the data. So we built in right through the system reports for the person doing. If you're engaging with a patient, you see the patient reports. If you're engaging at a hospital level, you see all the hospital reports in the same shape as the national or the Europeans will see them. So we tried to build that in sort of a context of whatever your context allows you to see that you can see the reports in that context. So this would be one example. It's pretty, not really sure what we want to show you other than, we've got groups of lung function, a number of patients or therapies or microbiologists, these types of things. We've got the countries or age type cohorts for growth in lung, FEV 1%. Very popular chart with the CF guys is the box plot of median FEV values. But to be able to do that through the different age groups or across different factors without having to request reports. So that's kind of one approach. Different approach then we've taken at the patient level. So this is the patient encounter form. What we've tried to do here, we got help information there. We've got the previous value. If the patient had a previous encounter, we expose the previous value so you can reapply this one or all previous values for certain forms, because sometimes you have an encounter but you're not doing the whole form. And if you want to pull out a report, so all the patient reports can be pulled out then in the context of the assessment. So the idea is that the doctor is meeting the patient, he's filling out a form or parts of a form. The reports have value only in the context that the doctor is saying, what were the previous values there? What was going on? We've implemented a technology called SVG. It actually will allow us to overlay all the reports on each other. So we get FEV values or body mass index or these types of things, plus the pseudomonas or the different micro events or the antibiotic events of people coming on and off. And we overlay them all in one chart. So we don't have to be rooting around through different data. So we start to do that here. And we're doing that in the context of the assessment form that's sitting underneath it. Just kill that just in the assessment. You can't get lost. A lot of the thinking is you can't get lost. You can fill the thing in under pressure, not having to try and go through training courses of how to use this software. Now, how good we are at it, we don't know. But we're trying to be good at it. We're trying to listen to the clinical people saying, I don't really want to do it that way. I don't want you to give me that information. A lot of the advice we're getting is give us information when we ask for it. Don't push a load of information out in front of me just because you can. I only want to see body mass index if I ask for it, because I've asked a question. And then I want to see medications or I want to see something. But don't be leading me, Just be very quick and prompt in responding to my question. So that's what we're trying to get at here. And lots of nice new web technologies are enabling us to do that. We pulled in technologies here from the financial services industry. I think the library called FOTS come from financial services. Really nice stuff. We just bang it in here. Got it for free. Cystic Fibrosis Europe get it for free. Where we're moving to is we're moving towards a shared enhanced encounter. So we're going to start enhanced encounter with things like lab data or other inpatient encounters. So that becomes very focused on cystic fibrosis with a much richer experience. We're just starting on that project. Where exactly it takes us, who knows? These are all a journey of learning. So, just at a technical level, all of this is done in free open source software. We use Postgres here. We use Postgres all over the place for all sorts of some very large databases. We're using Django as the web application framework, very popular Python-based framework. Like I said, we did use Devo of the Boston Children's Hospital, but we've actually pulled it out of the implementation, but we have used their document models and security models. And we've been using Devo in parallel with this where people want to do patient engagement and patient control on the record. So we built it in that model that it will work well with it, but patient engagement is not that popular really in Ireland. I did meet some skin people recently who were maybe more interested in some dermatology issues where they maybe wanted the patients to engage from their home. We have patient engagement on the joint registry, but the expectation is as done with the orthoplastic nurse that the nurse really guides the patient through it for a pre-op or a post-op. And we're using lots of JavaScript, like I was saying, from the financial services world. So that's our little story. That's a very focused application, built in open source, starting to integrate with the other hospital systems. Okay?